much. It's a true honor and pleasure to be here with you in this beautiful environment. And I congratulate you on the efforts to develop a new interesting agent. So I usually start with that slide, including the flags of the country I am in and Belgium. But I would like to thank you because I saw on the car, on one car that was driving us around, that there was a Belgian flag. So that's very kind of you, and I certainly appreciate. I don't think it was on purpose that it was there. I think it has been there for a while, but I noticed it. So it's my pleasure to address one of the most important problems in medicine, the problem of circulatory shock, or simply shock, because there are no other shocks in medicine except for electroshock, of course. And if we look on internet, what shock means, the answer is it is a sudden, upsetting, or surprising event or experience. And that's certainly true also in medicine. But I like this sentence: shock is a momentary pause in the act of dying. It's a situation between life and death. And Alain Delon, who died recently, interpreted this in this movie called The Shock. Now, in medical literature, we find in the initial reports that people focused on intravascular fluid. Is there enough fluid on board? Reduction in circulating blood volume. Cardiac output is insufficient due to a lack of volume. And Medline Plus says that shock occurs when the body is not getting enough blood flow and when the organs do not get enough oxygen and nutrients. So this quite long introduction to remind us that shock is not just hypotension. No, it's much more complex, much more profound than a symptom. It is the inability for the cells to get enough oxygen to function properly. So we need to start from physiology, and I'm not denying that hypotension is an important sign of shock, but it's not the only one by far. A vagal syncope is not shock. And on the other hand, as we wrote in this consensus paper a while ago, one may be in shock with a relatively normal blood pressure. So the issue is, inside the body, we need to look through the windows and appreciate the degree of organ perfusion. And to do this, we have actually 3 windows in the body. Let's consider them in a rapid succession. If we consider that the patient may be in a life-threatening situation, we start by looking at the fingers. We look at skin perfusion. Is skin perfusion altered or not? In vagal syncope, it may not be altered very much. But in shock, there is an alteration in this cutaneous perfusion, and this could actually be monitored. My former teacher, Dr. White, proposed many years ago to measure skin temperature. Of course, the measurements of capillary refill time has been there for many years. Some people now have a renewed interest in the capillary refill time but it's a relatively gross evaluation. It's not very objective. One nurse may not have the same result as another nurse. So some companies will actually develop some instruments for this, but it's not much better. There will be further other techniques. We have an interest in laser Doppler techniques, and it works pretty well to evaluate the skin perfusion. But the point is that evaluating skin perfusion can be very interesting because the changes will be really will take place very early in the process. So it may act us to act quickly. And when the shock resolves, the alterations in cutaneous perfusion will disappear at the very end. So it will help us to make sure that our resuscitation is complete. One element is sure, we need to always avoid vasoconstriction, which is not good for the heart, which has to pump harder against a vasoconstricted circulation, and it's not good for the cells that will see proportionately less blood coming to them. The brain is underperfused. Oh, the patients are sedated, we cannot evaluate that. No, that was true 40 years ago. Today, people realize that sedation is not necessary when the brain is underperfused. The patient is obtunded and would like to sleep. So, sedative agents should be avoided by all means. They can only further alter the hemodynamic status of the patient. And if the patient is more or less alert, we can do these little tests. And for instance, ask the patient to squeeze the end each time there is an A in the word we will pronounce. Casablanca is a very good word for this. C-A-S-A, etc. I would do it well, you would do it well, a patient in shock will do it certainly incorrectly. And the third window is the kidney. In shock, there is typically a reduction in urine output because the body will try to keep the volume. There is typically a reduction in circulating blood volume in shock states. We can now measure urine output every minute. Again, I have no conflict of interest. Some of these companies are doing rather poorly because they try to sell it for a high price and the advantage is limited. But instead of having the urine output in milliliters per hour, we could have it in milliliters per minute, or less than 1 milliliter in 1 minute. So that's an interesting approach. But we need a biochemical marker, and as we all know, that's blood lactate levels. The blood lactate levels in normal individuals is close to 1 milliequivalent or millimole per liter. In shock, it is typically above 2. It's a 60-year story. It is 60 years ago that lactic acidosis as a marker of shock was described. And of course, the higher the lactate, the worse the prognosis. This is a study of many blood lactate levels measured in Australia, and you can see that indeed 2 is some kind of reasonable cutoff value with mortality rates increasing significantly when the patients have a lactate above that value. Now, lactate levels increase in all forms of shock. It is a marker of shock. Some people sometimes say, oh, lactate levels are a sign of sepsis. That's wrong. No, I'm sorry. No. A patient with sepsis without shock has a normal lactate level. Again, The patient with a high lactate level may have some degree of hypoperfusion, a very mild hypotension. So this is a highly valuable marker. And we need to repeat the measurements over time. In this review, we could show that regardless of the etiology of shock, if we look at how the lactate levels decline, some people call it lactate clearance, but it's not clearance, it's production more than clearance. If the lactate levels go down, it's a good thing. Lactate levels may even go up even when they are still normal, before shock actually develops. Now, lactate levels do not change so quickly, so we can do the measurements every hour or even every 2 hours. It's not necessary to repeat the measurements every 10 minutes. That doesn't make much sense. So as I wrote here with Dr. Bakker, it's a way to evaluate from time to time where we are in this patient management. If the patient is improving and the lactate levels go down, okay, that's reassuring. If we think the patient is improving but the lactate do not go down, maybe we are too optimistic here. Maybe the patient is not improving so much. And the other way around. If we feel the patient is not improving but the lactate levels go down, well, maybe we are pessimistic. So these elements, I reviewed them with Daniel de Bakker in this paper on circulatory shock. And you can read it if you like. Now, I often hear people speak about hemodynamic instability. What do you mean, hemodynamic instability? Isn't it shock? Well, the patient is unstable. Okay, but what about a patient who is very stable on high doses of vasopressors? Would you say this patient is hemodynamically stable? No. So it's a very unfortunate word. And another important principle is that the patient may be very stable on the same doses of noradrenaline, but if the patient does not improve over time, the patient is getting worse. I thought about it when a young resident during a report in the morning said, oh, the patient has been very stable during the night on noradrenaline. And then when the relatives call, the nurses say, oh, no, there is no change. No, there is no change. Come on. It's very bad to remain on the same doses of vasopressors. Every hour will increase the risks of death. So a patient who does not improve hemodynamically is a patient who is getting worse. Very important principle that we need to repeat when we talk to the residents. Okay, let's go into, well, still the pathophysiologic alterations. Let's speak about the mechanisms. How could shock take place? Of course, hypovolemic is an important type of shock due to hemorrhage or trauma or diarrhea or other things. Could be a problem with the cardiac pump. Major myocardial infarction, terminal cardiomyopathy, valvular disease, I put it there. Even major arrhythmia, ventricular tachycardia, boom, can bring us not necessarily to cardiac arrest. There may still be some pulse, but cardiogenic shock. The problem is in the heart. Obstructive, no, it's not really in the heart. Tamponade could be a type of obstructive shock. When we take out the fluid which is in the peritoneal, in the pericardial sac, the patient gets better. Cardiac output comes back. Massive pulmonary embolism is a typical type of obstructive shock. And then there is the distributive type of shock. Alterations in the peripheral distribution of blood. It could be sepsis, it could be anaphylaxis, it could be pancreatitis, but it's a different process. So there are, if we think about it, there are only four mechanisms. It's important to look at it that way, because it may be more than one mechanism in the patient we are facing. You know, as a Belgian person, I like beer. And when I go to the cafe, and if I cannot get beer in my glass, I think there are four possible mechanisms. Either the barrel is empty, or there is a problem with the pump, or there is a problem with the in the tubing, or indeed there are holes in the tube. There is no other way to explain that I cannot get beer in my glass. So these are mechanisms that could be combined. Septic shock, it's not just distributive. It could be hypovolemic as well. It could even be cardiogenic as well. Cardiogenic shock may have a distributive component because there are inflammatory mediators released. So, you know, if you do not appreciate that, when you face a patient with cardiogenic shock and a normal cardiac output, you would say, no. Cardiac output should be low in cardiogenic shock. No! And that's the reason why the cardiologists even tried to give nitric oxide antagonists to vasoconstrict, to restore the vascular tone in patients with cardiogenic shock. Didn't work very well, but it was an idea. There is one fundamental equation in hemodynamics. Number one, and it's the simplest, very simple. Blood pressure is determined by cardiac output and vascular tone. Blood pressure is determined by cardiac output and vascular resistance, if you like. So, if a patient has an hypotension, we need to consider the cardiac output. If the cardiac output is low, there are only 3 causes of a low cardiac output. 3. Not 4, not 5, 3. Hypovolemia, cardiac problem, and obstruction. These are the only causes of a low cardiac output. And of course, a high cardiac output suggests that the blood is not going exactly in the right place. There are microcirculatory disturbances, and this is what we would see in sepsis, in pancreatitis, in anaphylaxis, etc. Or in some people call neurogenic shock. Okay, it's better to return to the mechanisms. So if a patient is hypotensive, let's evaluate the cardiac output. And if the cardiac output is low, then let's try to evaluate the degree of filling of the heart. Is it low? Is it a big ventricle, like in pulmonary embolism, major pulmonary embolism? Or is the heart pumping very poorly, as in cardiogenic shock? How shall we do it? We all agree, and you will see our next recommendations coming out at the end of this year. Echography is really the stethoscope of the present already and the future. Echocardiography is part of our tools. We cannot say, I cannot do that, I don't have the machine. Yeah. In the past, you could say the same for the stethoscope, maybe. No, you bought one. And you need to have echocardiography in emergency rooms in the ICU. Management of shock, very briefly, it will be quite superficial, I'm afraid. My former teacher, Dr. Y, was saying a patient is a VIP. Not only a very important person, but a VIP because we need to oxygenate, ventilate, we need to infuse fluids, and we need to take care of the pump. So, Of course, we don't want to give too much fluids. We are concerned about the development of edema, but hypovolemia is very, very bad, for sure. That may lead to multiple organ failure by the highway. Vasopressors can be needed, especially when the vascular tone is depressed, but excessive use of vasopressors is the road to multiple organ failure as well, but this time due to vasoconstriction. So I will briefly introduce the three challenges: fluid challenge, norepinephrine challenge, the butamine challenge. But before that, I will underline what people recognize today as an important way to look at shock management. There are 4 phases. The first one is just salvage. You don't have anything, you don't have any monitoring. The patient arrives in the emergency room, or you are called on the floor to evaluate the patient. Just try to keep the patient alive. Then there will be the optimization. We will see how much fluid the patient requires. We will see whether patient would benefit from Centhaquine, maybe. We will see whether we need to give more fluids to other inotropic agents. Then we will reach a stabilization phase, where things become indeed more stable. It doesn't mean the patient is out of the woods. No. It means that things do not change so much. Before the de-escalation, some people call it de-resuscitation. I don't like the word de-resuscitation, as if we were regretting our resuscitation. No. It's de-escalation. Let's decrease the doses of vasoactive agents. Let's decrease the amount of fluids that we give to the patient. So, VIP, we should not hesitate to intubate the patient with shock. We need to assess clinically. We could ask the patient to pronounce metoprolol. If the patient, that's the right time to intubate the trachea. We should not give too much oxygen, because we know that hyperoxia is not very good. I wrote this editorial in the Lancet to emphasize that we should actually try to keep the PaO2 within the normal range. In the past, we were happy when the patient had an oxygen saturation of 100%. Now say, no, the alarm will ring. No, it should be 96, 95, 94, 93%. That's okay. Okay, fluid administration, not too much, not too little amount. We don't want the patient to be full of edema. Here there is another word that we don't really like. It's the word fluid overload. The patient has signs of fluid overload. What do you mean? Is it edema? Or is it acute lung edema? Or is it edema without high cardiac filling pressures or with high cardiac filling pressures? So the term should be better defined. You cannot say we want to avoid fluid overload without saying what you mean. And we should never forget that an edematous patient may be hypovolemic, because those who are not intensivists, especially in the past, the surgeon who was coming to see the patient was saying, there is edema here, you need to limit fluid and give diuretics. No, maybe the patient needs more fluid and no diuretics. So the presence of edema does not really indicate for sure that you need to limit fluid administration. Think at just hypoalbuminemia that could contribute to that. And as I mentioned during the discussion the day before yesterday, if you have a massive myocardial infarction, you may have water in the lungs, and it may not be a good idea to give diuretics if the cardiac output is depressed. So let's move on, and let's say that during the salvage phase we give fluids quite generously, but we will need some form of monitoring. We cannot treat a patient with shock without some form of monitoring. Fluid with vasopressors, of course, we often do that. But vasopressors should not replace fluids. That would be a very bad idea. And there is no single variable that will tell us that this patient needs fluids. The heart rate may be high, it doesn't mean that the patient needs fluid. The blood pressure may be low, it doesn't mean the patient needs fluid necessarily. Lactate may be high, it doesn't mean that the patient needs fluid. Very important, we need to combine these elements. Now, there are some very important signs in patients who is, during surgery, anesthetized. If there is an arterial catheter in place, we could look at the fluctuations in blood pressure. If it's significant, it means that the patient is hypovolemic. But most of our patients will not be in this situation. So we'll have to test the system and give fluids and see if cardiac output increases with this particular intervention or not. So that's what we call the fluid challenge, when we don't know whether the patient needs more fluids or not. It's better to give a fluid bolus than to just increase the rate of infusions. That will correct it very slowly and may even overshoot. So it's better to give a fluid bolus and keep the infusion rate of the other solutions constant. So the fluid challenge is a way to evaluate the patient's response to a simple intervention, which is a fluid bolus. We cannot guess what the patient's response will be. There is a recent study from Australia, from Dr. Bellomo, where he asked the residents, do you think this patient will respond to fluid? Oh, yeah. Oh, no. Okay, let's do the measurements. Let's do the fluid challenge. And it gets all over the place. Actually, there could be underestimation or overestimation of the effect of fluids, in that case, on arterial pressure. But hopefully, we should have a measurement of flow. And that could be done by echocardiography, quite simply, evaluating the velocity time integrals. So practically, the fluid challenge should be given over a short period of time, 5 to 10 minutes, small amounts, and we need to see how the patient responds. If there is a benefit, we continue. If there is no benefit, we stop. So the time should be 5-10 minutes. We often hear people saying, let's give some fluids and we'll reevaluate the situation in half an hour. No, there will be too many things happening in half an hour. Moreover, if the patient does not benefit from fluids, he will get the fluids during half an hour, which is really too much. So in surgery, it's even 1 minute. That's what they call the mini fluid challenge, but we are not here to speak so much about surgery. The point is that the fluid challenge should help us to stop fluid administration when the patient does not benefit. It should not encourage us to give more fluids when it's not necessary. It's the other way around. It encourages to stop when not needed. Now, if there is an alteration in vascular tone, typically in septic shock, the blood pressure may not be a good indicator of the patient's response, because the vessels can easily dilate. And so, as you can see on our data here from some years ago, the blood pressure may not increase, but flow may increase in some patients. So, cardiac output measurement. But the technique used doesn't really matter. Maybe bioimpedance is not very reliable, but there are different methods to measure cardiac output, and echocardiography can do it well. So let's move on, and let's say that I will skip the passive leg raising test as it is, in my mind, a little bit more complicated to do. Now, it's only when the patient is in the stabilization phase that we can afford giving diuretics. Don't give diuretics during the resuscitation phase. That would be a mistake. We know that saline solutions can increase chloride levels. We know that hyperchloremia can alter kidney perfusion. So saline solutions should not be given too liberally to any patient. Don't do that. Measure chloride levels. It's easily done. If the chloride levels tend to increase, then we move to what we call a balanced solution, the Ringer's lactate solution, or the plasmalide solutions. Finally, pump. Vasopressor support can be started early on because severe hypotension is always bad. But in terms of target, the target can vary quite substantially from one patient to the other. So we recommend in septic shock 65 as an initial target, but it is an initial target. It needs to be reassessed. There are studies showing that even 75 may not be high enough. So that's what the Surviving Sepsis Campaign guidelines indicate. Initially, target 65. But people drop the word initially. They just say, oh, 65 is fine, septic shock 65. No. In our previous guidelines we wrote, if initiated, vasopressor dosing should be titrated to an endpoint reflecting perfusion. And after the most recent guidelines, some colleagues and I wrote this paper saying, you know, a military pressure of less than 65 may be okay in some patients with septic shock. And 75 may not be sufficient, especially in patients with a history of hypertension. So we need to evaluate the urine output, consciousness, the skin perfusion. Yeah, the windows of acute circulatory failure, and complement it with measurements of lactate levels. That's what we call the noradrenaline test. Dopamine has been abundant. You may know we did this trial comparing dopamine to noradrenaline in patients with shock, and dopamine-treated patients, if anything, had a worse outcome. Cardiogenic shock in particular, but in septic shock too, especially when you look at other studies. Adrenaline is not a good agent. Adrenaline is what we release when we are in real trouble, and it will decrease splanchnic blood flow. It will decrease renal blood flow because we want to keep our volume, but it's not good for the kidneys. So let's try to avoid these agents. I have no time to speak about vasopressin or other agents. I will actually finish up by indicating that if flow is important, and if we return to the 4 determinants of cardiac output, if we have given enough fluid to the patient, we think, if there is no good response to another fluid challenge, then we are left with the option of giving some dobutamine to increase the force of contraction of the heart, especially when there is some evidence of myocardial dysfunction or a low SVO2. It's quite important whenever possible, whenever we have access to a central vein, to take a sample and measure the SVO2. Now, in the future, I may add this slide. Centhaquine has a very interesting profile as an alpha-2b stimulating agent, and it has a totally different mode of action. But the idea of vasoconstriction, I believe, is an excellent idea that could help to limit fluid administration and perhaps limit blood transfusion, or at least maintain a better hemoglobin level, because it's the patient's blood which is put in the circulation. And there is no vasoconstriction, as we heard, and there could be a small decrease in heart rate. So these are a number of potential advantages. And so in the future, in a few years from now, we may actually put it at the very beginning of our management. We could say, okay, start fluids and give already some Centhaquine, so that from the beginning you will actually vasoconstrict a little bit the veins and recruit the blood which is in the venous compartment to help the heart to pump in the towards the organs. So let's put it together in closing. Fluids, vasopressors, potentially a dobutamine challenge if we think that blood flow is insufficient in the presence of adequate filling. So in the salvage phase, we start fluids, we start noradrenaline, we already do an echocardiogram. During the optimization phase, we may insert an arterial catheter and a central venous catheter to do fluid challenges much more easily. We evaluate the need for noradrenaline, we monitor cardiac output as VO2, and when the patient is hopefully stabilized, then we use only maintenance fluids and we taper down and stop the vasopressors, and then we may start the diuretics or ultrafiltration if the patient does not make urine. Now, I covered only one half of the management of shock, because obviously we need to treat the cause. The management of shock is maintain tissue perfusion and treat the cause. In hypovolemic shock, we may need a surgical procedure, cardiogenic shock PCA, obstructive shock thrombolysis, disruptive shock antibiotic, source control, etc. And we spend much time speaking about the maintenance of adequate tissue perfusion. But we should always avoid vasoconstriction and keep in mind that blood pressure is determined by blood flow and vascular tone. So we can increase blood pressure in emergency situations by increasing vascular tone, but we need at the various options to increase cardiac output, because it's much better to have a normal or high cardiac output with less vasoconstriction. So there are a number of elements to put together in this equation. That's the challenge. That's how it's a real challenge to treat the patient with shock. Thank you very much.
Hello? Yeah, since this is an invited presentation, normally we do not take questions, but as an exception, would you like to take one or two questions? Or?
You are the boss?
Yes. If there are one or two questions, we can. I think such an elaborate, right from basic concepts to explain how the shock mechanistically and systematic treatment overlapping one type of shock to another, one mechanism to another, and how to manage an overview. I think this was an excellent overview. Thank you, Professor Vincent. Thank you very much.
Thank you.